Hey, everybody. This is So It's Cancer. Welcome back. And it's a podcast to understand cancer, how it happens, how it's treated, how we arrive at a diagnosis and a prognosis, its impact on a person's quality of life, and how to move forward after a cancer diagnosis. Today, we are very excited to have Mernaz Mirzad and Zajansa Zahirsha, both with us from dermatology at Loyola University. And we're talking about skin cancer, not the melanoma type, just the non-melanoma skin cancer. So welcome aboard, you guys. Thanks for joining us. And Mernaz, would you mind just introducing yourself for a moment?
Sure. Thank you so much for having me. I'm really happy to be here. I'm Mernaz. I'm a dermatology second year at Loyola, dermatology resident. Before dermatology, I did a prelim year in general surgery, and I always really liked the overlap of dermatology, overlap of medicine and surgery together. So I think derm was the perfect fit for that, where you can get the patient interaction and also hands-on procedures and surgery.
Fantastic. So, do you think you'll be a Mohs surgeon someday, or you want to stick with?
It's hard to I can't tell that right now. It's hard to tell, but it's definitely in the back of my mind right now.
Great. And Dr. Z?
Yeah, Zasancha Zahirsha, or Z for short. I graduated from Loyola University Medical Center as a resident there in 2024, and I've been out in practice here, actually practice at Loyola, and I ended up in dermatology for a few reasons. I think the biggest one for me is like the skin is something you can see and everyone else can see as well. So there's a huge psychosocial impact to that. So it makes it really gratifying to treat others and see that improvement.
Well, and I'm grateful because you treated one of my skin cancers. So not to get too personal, but hey, it had to be done. All right. So today we're going to talk about skin cancers. We've already spoken about melanoma on this show about a year or more or two ago, and today we're going to talk about other types of skin cancer. The basic types are basal cell and squamous cell. That's the vast majority of them. Maybe 5% are a type called Merkel. There's 3 that are very rare. And then there's a lymphoma that can start in the skin, oddly enough, of all places, called primary B-cell lymphoma. And then a very rare one called Kaposi's sarcoma, which is almost never seen except in the context of HIV/AIDS, if I'm not mistaken.
Yeah, pretty much HIV or immunosuppression.
Well, would you guys like to talk about, we'll talk about these non-melanoma skin cancers in general as a group, perhaps, and about what would you say would be the predisposing factors to these types of problems? Who gets them?
Go ahead.
Okay, thank you. So I think anyone can essentially get skin cancers, but there are some risk factors that predisposes you to getting skin cancers. One of them is having fair skin, UV radiation, meaning being out in the sun. And that can be a cumulative damage throughout many years, or it could be even intense episodes. For example, as a child getting multiple sunburns, that can also be another risk factor. Other risk factors are immunosuppression. So patients who are either through surgery, through multiple other reasons, immunosuppressed through medication, or organ transplant patients, or any other reasons for them to be immunosuppressed, that can also be a risk factor. Other things are genetics as well. Sorry, go ahead.
No, I was just going to ask, when you said an intense episode, like as a child getting a sunburn, is that something that shows itself decades later, or is that something that you're seeing right away?
Yes, exactly. It will be decades later.
Wow.
That by itself is also a precursor for especially specific types of skin cancers, like for example, basal cell carcinomas will present that way.
What is a basal cell carcinoma?
Oh, yes.
That's a great question.
Exactly. Yes. So that's actually the most common type of skin cancer. It's the least aggressive type. It's very locally destructive, but it doesn't really metastasizes. So by itself, we're not really worried about any systemic involvement, any nodal involvement. But if it happens, for example, on areas or anywhere, like for example, the nose, it can get very locally destructive. So
and this is primarily from like a sunburn, or
it can be from
exposure?
sunburn or any of the other risk factors that we discussed, and even tanning beds. I forgot to mention tanning beds. Those are the worst ones.
Well, like Michael, I mean, probably like I spent my entire childhood sunburned. There wasn't a photon. There wasn't a photon I ever met that I didn't like, and
I was just thinking, like, oh my God, I got to worry about the like terrible sunburns that I had as a kid.
Yeah, yeah. And as we get older, it's going to be even worse. But yeah,
is there something that to my doctors? Is there something that like I know I've had severe sunburns as a kid. How would that manifest itself, and what would I be looking for? Like, do I have to remember exactly which shoulder was worse, or?
No, I mean, usually when I hear of a patient having like a history of blistering sunburns, we just know that you're at a higher risk for skin cancer. So the same goes for any location. The biggest things you're looking for are bumps or new growths that are like bleeding, itching, painful, the sore that isn't going away. Those are kind of the stories, especially for these non-melanoma skin cancers, of something to be concerned about. So just being on a keeping out a close eye for any new or strange growth or something that's not going away is probably enough reason to go have it checked out.
And you'll think like this is just let's say, all right, my first skin cancer I was in my mid-20s, and there was this thing on my face, and it wouldn't heal, and it would heal, and then it would open up again and heal and get up again. And I was newlywed, and my wife was like, "You need to get this checked. It could be a skin cancer." And of course, I was a little know-it-all, and I was like, "No, I'm too young," you know. And I was also heading off to Okinawa for a year and a half with the Marine Corps, and so I finally go and check it the last moment I possibly could. And wouldn't you know, it's a basal cell, and it's a morpheoform, and we'll talk about that in a second. And I needed Mohs surgery. We'll talk about that in a second. So I had this huge scar, and she was right. So that was probably the last time I ever, she was right. She was like, that was a skin cancer. And
yeah.
I was too young, but all those sunburns as a kid,
Yeah, even then, I guess I've learned through practice, there is no such thing as too young. Depending on the type of skin cancer or your genetics or your risk factors, it can happen in kids. Obviously, the older you are, the higher risk you eventually become with all the sun damage, but there are other reasons people can get them a lot younger.
Oh.
All right, Mernes, would you want to talk a little bit about precursor lesions?
Yeah, for sure. So we have multiple different precursor lesions. For example, actinic keratoses. These are we just call them for short AKs. These are these kind of gritty, pimple-looking areas. I would say like hyperkeratotic papules that can happen. There are these gritty, textured unevenness of the skin. And please, Dr. Z, interrupt me if you have a better way of describing them.
I usually tell patients it's like when you feel sandpaper on your skin, you might be dealing with an AK. They're sometimes a lot easier to be felt than seen. So that, I think of it as like sandpaper.
And this going to be on any part of your skin in any part of your body?
Technically,
not just
yes.
sun exposed, but like anywhere.
I would say technically yes. Most commonly, it would be a sun exposed area.
Okay.
For sure.
Yeah. And so those would be precursors, for example, to squamous cell carcinoma. However, not all of them would turn into squamous cell carcinoma. The rate of them turning in is probably 1 out of 100. However, we still will treat them because they do have that potential.
Yeah, I mean, the transformation from an AK, which we call a precancer, to a squamous cell carcinoma, a true cancer, if you let 100 go for like 10 years, one of them would turn into a skin cancer.
I didn't realize it was that low. Yeah.
Yeah, it's like 0.1%
Okay.
per year. So like by itself, it's not super scary, but they easily rack up over the years, which is why we recommend treatment for them.
Oh, if you have half a dozen of them and you have them for 30 years,
exactly,
the numbers add up.
Exactly.
I think
half a dozen sandpapery areas on your body.
Yeah,
this is a common thing.
Yes.
Jesus.
Yeah,
All right.
Especially on the forehead, temples, back of the
Check.
hands.
Yeah.
And you know, I think that is an important thing is if your skin is from, like, let's say a very northern latitude, but you're living closer to the equator than nature had intended for you, you know, like the most dramatic is people from Scotland that go to Australia. You know, they're built for clouds and rain, and now they're baking in the sun. People who don't tan at all, they just go from know, pale to burnt.
Red. Yeah.
Exactly.
That group. And then, you know, in terms of exposures, like how do you, all right, you say, okay, well, I live down here. I'm living in Florida, or I'm living, you know, in Mexico City or whatever. What do? You have to be careful. You have to avoid, you know, in the middle of the summer, in the middle of the day is like the worst time for you. You know, the sun's just going to cook you. So you have to be sensible about those issues. Anyway, back to the precursors. I guess like there's Bowen's disease and keratoacanthomas, KAs. Do you want to touch base on those?
Yeah, absolutely. So for Bowen's disease, Bowen's is essentially the squamous cell carcinoma that is contained within the first layer of the skin. So it still has not fully developed into a full-on squamous cell carcinoma because it hasn't broken that barrier of metastasis down to the deeper tissue. So it's essentially, we call it squamous cell carcinoma in situ. The other one, the keratoacanthoma that you mentioned, these are also very rapidly evolving squamous cell carcinoma-like lesions. Debate whether or not they are actually squamous cell carcinomas and whether they will involute by themselves if you leave them. But we
What's an involute?
Yeah,
just like going away. Just going away.
Okay.
Yes.
It's not going to heal itself.
Yes. There are, yes, but we still treat them as squamous cell carcinomas.
Yeah.
So it sounds like this is surface. Like it is cancerous, but it's so shallow on the surface. And we've talked about this on some of the previous podcasts about the depth matters.
Exactly.
So you're catching it early. One of the things that we always talk about is getting into your doctor early, and usually it's your GP and getting things checked. So this sounds like one of those, like, go get it checked right away. Unlike, you know, what Paul was saying about in his past. If it's a surface thing, that's a good time to catch it, right? Because otherwise it will go deeper probably.
Exactly. So the Bowen's disease or squamous cell carcinoma in situ, how I try to explain is in situ actually is Latin for in place. So it just means the cancer is in place in the top layer of the skin. So they have a 5% risk of diving deeper and becoming a full-blown cancer. So you're right, like, you know, you have the opportunity to catch it earlier. You have no risk of spreading to other parts of the body. You have, as we'll discuss, options in terms of treatment to reliably cure yourself of it. And then, as Dr. Mirzad mentioned, you know, keratoacanthoma is an elusive term. I would say the majority of dermatologists kind of treat that as a squamous cell carcinoma. Most of the treatments for it tend to be the same. The unique aspects are that, like a keratoacanthoma, can tend to happen with trauma and can be really fast growing. So, we see people all the time, they kind of bump their hand, and literally a week later, they have a golf ball sized nodule on their hand. And you're like,
Oh,
how did
Wow.
that happen?
Yeah.
So that tells us it's a little more of that Ka type. But the good news is those actually tend to be the less aggressive kind of squamous cell carcinomas, even though they like grow very quickly.
if it grows deep, it's starting to be serious. But then you said a golf ball sized lesion. It sounds like it's growing up and out rather than down and in. Okay.
Exactly.
That's-
The Kas are kind of like almost like a volcano phenomenon rather than like the scarier squamous cell carcinomas we see. It's still one we treat as a squamous cell carcinoma, but I would say it's not a high risk feature of it.
Okay.
The two most problematic characteristic behaviors of any cancer are invasion and metastasis. So invasion is it's moving from where it began into the stuff around it. And that's it goes deep, and then it can go, whatever cancer we're talking about, and to go into whatever's next door to it. And then metastasis means the cancer, it breaks away from the mothership and it sends out into other places in the body. And, that could be the lymph nodes, and then it could be other organs. So with the in situ lesions, the, Bowen's disease, the squamous cell in situ, AK is not a cancer yet. It doesn't have the features under the microscope that would make it, anyone looking at it, say this is a cancer. Bowen's does, but it just hasn't invaded yet. And then KAs are just this bizarre phenomenon that kind of breaks some of the rules, but turn out to be not that likely.
Wait a minute. I need to reset here for just a second because
Raj.
I didn't realize we were talking about AKs and KAs.
Yeah, sorry about that.
Just a quick, give me a quick reminder.
Exactly.
An AK is the sandpaper one, and
Yes.
the KA
Yes.
is the golf ball one.
Yes. Beautiful.
Exactly. There you go.
Looking for
All right.
sandpaper and golf balls. All right.
All right. And with that, I guess we could move on into just overall levels of risk. And again, we're primarily talking about basals and squamous, which is, let's say, 95% of the whole group of non-melanoma skin cancers.
So
thanks.
for risks for basal cells, basal cell by itself as a category, it's lower risk. So it means that it's not aggressive type of cancer. We don't worry about it going to the nodes or metastasizing anywhere. But by itself, it does have some subcategories that can determine the treatment options available. So for example, there are some subcategories to basal cell. It's the superficial type. That one is the least aggressive type. Then there's infiltrative, nodular, micronodular, morphiform. These are more aggressive, means more local destruction, especially in specific places. They can really go deep. So for those ones, the treatment options changes. So for example, for the very superficial ones, we can use topical therapy. But for the very deep ones, like the infiltrative type, the standard of care kind of changes.
Yeah, I mean, if I had to like classify when you're thinking like, oh, is this low risk, high risk? What do you do with this? There are two components to everything. One is the patient, which we kind of discussed. There are some predisposing factors, but there are aspects of the patient that could make them more high risk. Most commonly tends to be like immunosuppression or some way to decrease the immune system, like we discussed, like organ transplant, or you're on some intense medications or chemotherapy or something like that, that lets a cancer, whatever it is, be easier to spread in your body. And then there are aspects of the cancer itself. And as Dr. Mirzad mentioned, the biggest ones I would say are size, something that's a little pea size is just going to operate a little differently than the one that's a golf ball size overall. Two is location. Head and neck tend to be the higher risk locations. There are other high risk ones, such as like special sites, like the genitals or like the hands and the feet, things like that. And then three would be what you see under the microscope. There can be aggressive features under the microscope that would come in like a pathology report you would see as a patient that would point you towards one treatment option over another.
Excellent. So for both basal and squamous, they have categories of low risk, and most of the tumors that we ever see are going to fall into that category.
Yeah, I would say the majority would be low risk if they're like below the neck. But the irony is, I would say a strong percentage of the skin cancers we deal with tend to be head and neck cancers, right? That's where you get most of your sun exposure. So by default, those are technically higher risk.
High risk, yeah. And actually, I don't do head and neck, so
yeah.
So I sort of was a little self-obsessed when I said that most that I see are low risk, but I see a lot of high risk that come my way. And then, so what sorts of features, Renaz, make something high risk or very high risk?
Yeah. So, for example, for squamous cell carcinoma, there are some categories. So, if it's more than 2 centimeters, that's going to be a higher risk for squamous cell carcinoma. There's if the patient is immunocompromised, that's another higher risk. If the thickness is more than 6 millimeters, so meaning that it's going down to the fat layer. If when they look at it under the microscope, they see that it's around a nerve, so we call perineural invasion. These are all features of it being high risk. Other things is if you look at it under the microscope and not be able to really distinguish where the cell was originated. So like if it's poorly differentiated type of SCC, that would also be another high risk features.
Other things that may not be listed that can make something a little more high risk, specifically with like squamous cell carcinomas, is that it can, as I mentioned before with those KA or golf ball size things, it can happen in trauma. So you can actually develop them in chronic scars or ulcers. If someone has a leg wound that's been there for years, you can develop a skin cancer within it. And it can be very hard, one, to even recognize there is a skin cancer there because you've just already been dealing with this non-healing wound. But you can develop, due to that trauma and, all that activity happening, a skin cancer. And those can be even higher risk. They're harder to identify, they're harder to cure because they're all messed in with all the ulcer and scar that's going on.
They're much more aggressive, more likely to jump from the site to the lymph nodes and also to the organs after that. So low risk means it's a local problem and maybe even a big problem if it's near your eyelid or on your nose or near your lip but it's something that you can manage with treatments, and it's not likely to jump to either the regional lymph nodes or the distant places. High risk has a bit of a chance of this, and very high risk, you're really concerned. If you've got a squamous cell that's already moved to the lymph nodes, then you've got a very dangerous situation. It's a full-on cancer like every other one that you treat.
Yeah, exactly. The average squamous cell has maybe like a 4% chance of spreading to other parts of the body. So, but if it does do that, that's a big deal.
So to get to the treatments, let's talk about treating the primary lesion. What are the array of treatments you guys might propose to a person if they come in? They've got a lesion, they saw something unusual on their skin or it felt weird, and they brought it to their GP. Their GP said, "Yeah, I'm concerned," and they sent them to you.
Yeah, I mean, This is one thing I enjoy about dermatology. You know, there's a lot of different treatment options, and we're very blessed that a lot of the cancers we talk about are curable. You know, when I talk about treatment rates, I'm talking about like cure rates. We're very blessed that most of the things we deal with can be full on cured. So the first category would be like topical creams. So there are a couple different creams that can be used for skin cancers. One is called imiquimod. This is like on label, so you know it's approved for use of superficial basal cell carcinomas, superficial BCC. This is the least aggressive type of basal cell carcinoma, and it's typically used for ones that are in low risk locations like the trunk or extremities. It's a cream that like essentially just gets your immune system to ramp up and target the skin cancer when you put it on and attack it. The cure rates, you know, they can vary 70 to 80% range, I would say, and you do have to use it for a decent amount of time. Typically, like at least 6 weeks.
It seems to
Nice.
be good. Now, does this teach the body how to prevent future ones, or
I wish.
yeah?
Not that I know, not that I've ever
All right.
seen that it really teaches you to do it. It just gets your body to identify that area you're putting on the cream. But you will have to deal with can be a gnarly rash during that time when you're treating it. The reaction can really vary patient to patient. It could be anything from like just a meh, kind of annoying little itchy rash to like, you know, essentially almost like an
Oh,
ulcer.
wow. Yeah, mine
Yeah.
wasn't too bad. Yeah.
Yeah.
Is the patient going to actually be able to apply the topical treatment all the time? So that's one of the other things that we also take into account is like patient specific treatment. Other ways of treating it, if they're not a really good topical treatment therapy candidate, for example, is just difficult. It's at a location that is like on their back. They cannot reach it every day and they don't have anyone to help them with it. Then we have other options. We have other options like what we call ED&C, electrodesiccation and curettage. Bear with me. It's just a scrape and burn. It's essentially a procedure that can be done in the clinic. It takes about 10 minutes. You numb up the area because you already see the outline of the cancer outside. And then you can just use a sharp tool to scrape the area first. The cancer cells don't really have that adhesion that normal cells have. So you really easily can feel them slough off. So you scrape the cancer out and then burn the area. So you do that 3 times. It's scrape and burn method to make sure you get all the cancer out. Then the patient will be left with a little kind of like a scar, essentially, that they should take care of it for the next couple of days.
What would you recommend to people who might hear that treatment and like now not want to go to the doctor because they're afraid of that?
Anesthetic. You will not feel any of this. And that's what I always say. The worst part of the procedure is just that numbing. And everyone who is a candidate for this procedure has already gone through that during their biopsy. So I say it's exactly the same injection that we use during your biopsy. It's just a tiny little pinch and a burn. And then after that, you're not going to feel anything. The good thing about this procedure is that you do not have any restrictions. You don't have to take it easy for a couple of days because your stitches might come off. After we're done, after 10 minutes, you're completely done. And so there's no really downside to your recovery, essentially.
Okay. Makes me feel better. Thank you.
Yes.
Everyone who might be listening to this is, why would I not do that scrape and burn over any like excision or massive surgery?
Just think, I got this little thing. I'm afraid of going to the doctor. It sounds bad, but yeah, to your point, for those of us who don't go to the doctor regularly, any excuse, it seems, and that fear of going. But to your point, but if you go and you take care of this small thing, you're avoiding, I'm sure, what you're going to tell me in a few minutes.
Yeah, a bigger surgery, which is what the other treatment option, which would be like a wide local excision. So this is where you numb up the area just as you did for your biopsy, this scrape and burn with the lidocaine cancer, and then you kind of cut it out. Usually it tends to be kind of cut out in a football shape almost, to kind of stitch it up in a line. So the benefits of this is obviously you're surgically removing the cancer and you're sending it to the lab so that the pathologist under the microscope can look at the margins and say, okay, we don't see anything on the slides we saw. So you get that report back saying that they didn't see any skin cancer left. And then you're left with stitches usually, and then typically a line scar that tends to be 2 to 3 times longer than what the skin cancer was. But this requires a little more recovery. Usually you're left with like a big bandage you have to keep dry for a couple days. You have to take it easy for a couple weeks, where depending on where the location of the procedure was done. And then there are higher risks of like bleeding, infection, numbness in the area, and you trade it for that scar.
See it, and I think I should go to the doctor, but I'm not going to the doctor, and I know it's going to hurt. But is there like a time frame of when it goes from something that's scrapable and burnable to something that's got to be excised and stitched over?
I'd say there are a lot of skin cancers that could be treated with either option, depending on patient preference, as well as, the pros and cons, I would say. The pros of the wide local excision tend to be the slightly higher cure rate. So that scrape and burn can be somewhere between like 89 to like 92% cure rate. A wide local excision is closer to like 95 to 97% cure rate. So it's slightly higher. And two is with that scrape and burn, you're not sending anything back to the lab to say, okay, the skin cancer is all gone. Versus an excision, I take that skin and then they look at it again. So then you get a second report saying the skin cancer's gone. So depending on the patient, they may feel really strongly about having a second report, or especially the scars look a little different. This scrape and burn has a little circle scar because you just kind of scrape the area. But if depending on the area you want like a cleaner line scar, then yeah, you're probably going to have to cut it out and stitch it. So, but I would say, yeah, if something is becoming larger and you let it go for longer, then it's not going to be as easy to confidently cure it with a scrape and burn. And you may be more inclined to say, yeah, we should probably be cutting this out. And then the other reason would be those higher risk features we talked about. If something under the microscope says this is a higher risk skin cancer, the scrape and burn may not be as good of an option because it's not going to get as much down there. And so that would lead to a higher recurrence rate. So you're going to be more likely to cut it out.
This might be a good moment to talk about the difference between a standard excision and Mohs. We introduced Mohs earlier, Mohs, not like Larry, Curly, and Moe. I don't know who Dr. Moe was originally, but I'm guessing Dr. Moe invented this technique.
Yep, correct. Dr. Frederick Mohs invented this. Mohs micrographic surgery. One other term you might hear is PDEMA, or peripheral and deep and phos margin assessment. Essentially, all it is you have the benefit of looking at all margins of a skin cancer 100%. So when you do an excision, you cut it out, you send it to a lab, and those people look under the microscope. But based on how they process it, you actually only look at less than 5% of the entire block of skin I gave them to make their, report that the margins are clear. Mohs surgery is a little more involved because you actually process that tissue in-house. We process that tissue. It could take anywhere from like 20 minutes to like 45 minutes to an hour. And the Mohs surgeon will actually look under the microscope themselves and see if there's any skin cancer left. If they see anything there, they come back and they take a little more exactly where they saw it. And they do the whole process again. You hang out again, we process another slide, we see if there's any skin cancer and do it again. So you keep doing that until the skin cancer is all clear. Naturally, because you're doing this in such, I would argue, like a more methodical way, the cure rate is higher. You know, for a standard basal cell, it can be as high as 99%. But it is a little more involved, both time intensive, resource intensive. So it's not necessarily used for every kind of skin cancer based on how high risk the skin cancer is.
Translation on that is insurance companies won't pay for it as readily.
Exactly.
Okay.
Yeah. But, you know, like if you think about it, what we were talking earlier, so many of these cancers happen in your head and neck. So if it's near your eyes, your nose, your mouth, your ears, this is really high rent territory. You want to save every little bit you can. You know, I mean, imagine one right underneath your eyelid here. Like it's a big deal to remove even a little bit of that tissue. And so with Mohs, you can remove the least amount of tissue and have the most confidence that it's not coming back.
Exactly.
When it does come back locally, it's a problem. It's, first of all, it breaks people's spirits. They're like, it's back. And second of all, you have to do the whole thing all over again and take more tissue. And third of all, when it comes back, it can come back more aggressive than it began. It sort of learned something through this whole process the first time, and it comes back meaner. So it's in everyone's best interest to get it out completely the first time.
There's actually like a criteria, it's called the appropriate use criteria, that guides providers in understanding like what skin cancers could be appropriate for Mohs. If a skin cancer is appropriate for Mohs, it doesn't mean Mohs is the right answer for that patient. It just means it would be an option for that skin cancer. So it's still always a discussion with a patient because depending on their life circumstances, their age, it might not be the right treatment choice. But yes, if it's on a high risk area, which is neck up, you know, hands, feet, genitals, if it has high risk features, if it's greater than a certain size, definitely if it's greater than 2 centimeters anywhere, or if then the patient is like immunosuppressed or at a higher risk.
Awesome. Renaz, would there ever be any circumstances where radiation is a good idea to send them to the radiation therapist?
I think so. I think there will be, if someone is not a good candidate for any of the things that we already talked about, and like for example, they're very frail and fragile, and they're already immunosuppressed, or there's plenty of ways why someone is not a good surgical candidate or like a topical therapy candidate. Definitely, radiation can play a role in that. And we can refer them for radiation. But I believe that the standard of care for these cancers still would be excision and everything that we already discussed.
How about when are systemic therapies appropriate for skin cancers, non-melanoma skin cancers, whether it's immunotherapy or chemo or small molecules or, oddly enough, antifungal?
In genetic disorders, like there's this genetic disorder with basal cell carcinoma that patients make a lot of basal cell carcinomas, and this is a lifelong thing. That is one of the areas where this can become useful on very highly aggressive types of skin cancers. The squamous cell carcinoma has metastasized to the nodes, and it's already very aggressive. Those will be a good time to use the systemic therapies.
In my sense, like when they show up to me, it's because it's jumped into the lymph nodes. And
exactly.
When it's in the lymph nodes, or if it's like, let's say it's a huge cancer, like now and then we'll see one that's 10 centimeters or something. And
exactly.
And some of these newer medicines are pretty incredible, aren't they? Like, you know, the checkpoint inhibitors, like cemiplimab or or any of these others they're pretty good. They're brand new and they work well.
Yeah, I mean, I think it's completely revolutionized how honestly all cancers are being treated. You know, these checkpoint inhibitors are being used for pretty much all like solid organ cancers. So in skin cancer specifically, I would say cemiplimab, pembrolizumab, things like that, especially for squamous cell carcinomas, is being more often used, and for basal cells that do not do well with those small molecule inhibitors you were alluding to. It really just gets your immune system to like fight the cancer, and it revs it up. And I would say there's even new research into potentially like injecting this into like local skin cancers. And all of this is with the goal that your immune system can now attack this and shrink it, and fight it that way. So it can be used in combination with surgeries. It could be used instead of surgeries potentially. It really just depends on the case. And this is kind of where working together as a team across like specialties for a patient is crucial.
Oh, it's cool. It's an exciting time to be practicing.
Is this something that a patient might ask for? Like, occasionally you might have some information doing your own research or something. And are there therapies that aren't usually presented to a patient and they might kind of self-advocate for something?
That's a good question. I would imagine cemiplimab is probably not something that a patient is coming to me specifically asking for, because it's usually heavily discussed with like a hemonc physician as well, or it can be like an intense infusion. So usually patients aren't coming to me demanding chemotherapy or immunotherapy, quite frankly. But as it becomes more common, there'll be more and more articles about it that people will see. But yeah, I would say it's something that is probably more likely to be discussed by the physician, because we're now kind of moving away from the older times of no matter how bad it is, we just got to try and cut this thing out. Now we're far more often to try a multi-pronged approach, so to speak. So.
I think, Michael, for the vast majority of these, which are low risk, the systemic treatments are probably too much because they come with side effects. They come with some serious side effects, for the most part. But if it's a high risk or very high risk situation where maybe it's already jumped to a lymph node, that's a small percentage of the overall group. But for those people, these medicines that are brand new and coming out all the time, that's when these really are effective. For our next topic, it's just anything that's specific to either basal or squamous that's worth mentioning. We've sort of talked about them independently and both as a group. For anyone listening, are they essentially the same, or are there a few important differences?
I think one easy way to think about it is basal cell carcinoma, don't get too worried about it. It definitely still needs to get dealt with because of the local destructions, but it won't kill you. Squamous cell carcinoma, it can be a little bit more aggressive. It does have the potential to metastasize and go to different parts of your body. So be a little bit more worried about.
But wait, I just want to say, I would not know the difference, right? Like if I've got something on me, go to the doctor.
Yes, that's right.
Worry about it until you tell me not to, right? Like,
yeah.
Yes,
I'm going to worry until you say,
that's right.
Don't worry about it. This one's not going to kill you. Okay.
If it's not healing, if it's crusting, if it's painful, if it's not going away, definitely get it evaluated. But yes.
Great point. Would you guys like to spend a few moments on Merkel cell?
Sure. Merkel cell, as you mentioned earlier, it's much rarer compared to like our basal cell carcinoma or squamous cell carcinoma, but much scarier, I would say. the risks of spread and death are just a lot higher with it, quite frankly. There's a few different like risk factors to consider. I like to think of like the AEIOU, which is like age, or like age, elderly, and immunosuppression, older than 50 years, and then ultraviolet exposure. So a non-painful bump that's really growing rapidly in people who are higher risk, immunosuppression, older than 50 years old, and then tend to be in fair-skinned individuals on areas exposed to the sun. So all of those can be like the signs of a Merkel cell. The treatments for them are just need to be more aggressive. It usually involves a pretty aggressive excision of it, as well as checking all the lymph nodes, as well as radiation. And so it's definitely something that if you've identified, you want to take real seriously.
And it can start off like a little red spot. Is that right?
Yeah.
It's so weird. I haven't seen them for years, and then I had a couple in 1 year. Patients come in with it, and is very aggressive. Took a lot of surgery, and radiation and immunotherapy, and it's different from basal and squamous. This is one that's far more likely to gallop away.
Yeah.
Well, guys, any final?
Oh, wait! I got to get some free medical advice.
All right,
Got three doctors.
Yeah.
So I was born with a bunch of moles on my back, which I can't see, but doctors all my life said keep an eye on those.
Yeah.
Thanks, Doc. What are they worried about, and what kind of things can happen? And are we talking about basal cell? Are we talking what's happening potentially to the moles that I have?
So for the moles, what I would assume they're worried about melanocytic lesions for like them becoming cancerous. And depending on genetics, with a family history of any type of atypical moles or any type of melanomas in the family, those would be the concerning ones. And then you want to keep an eye out for the ABCDEs of melanomas, for asymmetry, the borders, if they're changing at all, if the color's changing at all, those will be the red flags for possible something going.
Melanoma to melanoma. Yeah. Patients don't care. Is it melanoma? Is it non-melanoma? Just take care of it.
Get it out.
But the thing is that's tricky about those moles. First of all, you can't see them. So exactly. You should photograph them and have a photograph so that in 6 or 12 months, you can photo it again and compare the two photos. Melanomas can happen in a mole that's already there, or they can happen in a spot that had no mole and now you've got one. Mm-hmm. So it could be a mole that changes, or it could be just a brand new spot. So either of those circumstances, you deal with it. But I think the underlying theme, whether it's melanoma, non-melanoma, is your skin is, it's the largest organ in your body. So there's tons of cells. Any of them can decide to go rogue and become cancerous. And so if you are, concerned about skin cancer, as we all should be, you should keep an eye on your skin. And if there's any changes or any abnormalities, bring them to someone's attention. I think there is, these days with the internet, there's a lot on the video that you can see. You can probably even photo it and ask Google what it thinks. It's going to put us all out of work.
Yeah.
Mernas.
Dr. Google.
Yeah. Anything, Dr. Z? Yeah. Anything to add?
When in doubt, get it checked out.
There you go.
Yeah.
All right. Well, everybody, thank you very much for for participating, and thank all of our audience for paying attention. And any suggestions, please let us know what topics you would like us to cover.
Absolutely.
Thank you. Thank you so
us.
much for having us.